I call upon Dr. Sahithya Bhaskaran to talk on diagnosis and management of cerebral visual impairment in children.
Good morning. Thank you for the opportunity. I'll be talking on cerebral visual impairment, diagnosis and management. I'll try to cramp it within 6 minutes. So the evaluation from routine pediatric is different in the sense that you'll have to do a thorough medical record review for other problems and perinatal problems that are in the child and the drugs that the child is on, and also observe the child when the child comes into your clinic. An interview from caretakers, the specialists is very important. With a standard ocular examination and best corrected glasses, a functional vision exam is mandatory in every child with CVI. So points of interest in visual acuity, it should always be age and ability appropriate, because these children do not cooperate well with you. A fixing following is not enough. Always try to get a preferential looking acuity. Distance visual acuity, it will always be done, but near visual acuity we don't do in children that often. But in these children, a near visual acuity is what is important, because rehab starts from there, and that is the vision that the child is going to use. Accommodation is very important in these children, because they'll always have some problems with accommodation. A simple dynamic retinoscopy will tell you if they have an accommodation lag. If there is an accommodation lag, they will have to go in for a plus glass. Most of children with ASD and ADHDs will have a lead of accommodation, while others with CVI typically have a poor accommodation. And for every child that you assess, always look at the latency period, meaning the time that the child takes to respond to a test, and that time period or latency period should be given for every single test to allow the child to respond. Remember, always present single optotypes. If you're worried about amblyopia or you want to know the interocular difference, you can use single optotypes with crowding bars. Do not ever convert grating acuity to optotype acuity values. And the most important point here is the functional visual acuity for every person, be it typical or CVI or vision impairment, is always 2 to 3-fold larger than the actual measured visual acuity. Meaning, if N6 is your threshold, if the smallest font that you see is N6, you would not prefer to read N6 throughout your daily life. You would rather prefer a reading font of N10 or N12. That is what these children also do. So if they measure 612, don't keep presenting them 612. You have to go for a 618 or 624 as a functional working font. Functional vision assessment. Contrast is very important, because that decides your communicable vision. The visual field, despite the central visual field, inferior field is always affected. So always look for the inferior field. Discrimination, ocular motility, visual guided search for optic ataxia, and simultaneous agnosia. These children cannot process two things at one sense, or they cannot do two senses at one time, meaning they cannot see and talk, or they cannot see and hear. So always differentiate with one sensory input. The intervention, the aim of intervention is to reduce the visual disability and to minimize social disadvantage. So basic principles, everything should be clutter free, boring background, solid shades, always assess with best glasses. The ambient room lighting is very important. It is not that these children should be put in dark rooms. Ambient room lighting is what is ideal. Sometimes they do well with low illumination. And functional vision assessment is mandatory. They need breaks, so always give them their breaks and include the entire caregiving team. Glasses always should be given. Any refractive error, because these children are very small, do not go by APAO guidelines, Indian guidelines, all that doesn't work. Any refractive error should be corrected. Reason being, improves clarity, improves magnification. Children with hyperactivity, they work as peripheral blinders and cancel out the peripheral fields. Accommodation also they help with. And again, please note down the functional visual acuity for all practical purposes in these children. Environmental modifications, the 3Ds, depending on the developmental level, diversity and duration. Use plain backgrounds, the ambient lighting, and simplify the visual array. Always give what contrast they have to work with, where should they be seated, and the important writing materials for learning and in school. Visual field, when you have a lower visual field, this decides the mobility. So always make sure there is a suprathreshold stimulus, because visual field is a relative field in these children. So if you use a higher stimulus, or if you train them, they get better. And if there is a preferred visual field, always present objects to the preferred visual field. Like this boy only had a superior field, so always try and present it to their seeing field. And visual array should always be simplified. And when you have children with simultaneous agnosia, in a say in outdoors, they will always prefer approach magnification. While you're reading and all, you can give simple one optotype and reading guides and all that, but when you're in the outside world, they'll try to go close to it. That is a coping mechanism. Don't stop them from doing it. Typically parents will tell they're going close to the TV and watching despite having a good vision. Don't keep pulling them up behind, because they're actually using approach magnification to cancel out the simultanagnosia. Sensory integration, when you mean vision, don't keep saying you have to see and you can't hear or touch. It should always be augmented by auditory as well as tactile, and that is how children learn visually mediated concepts as well. Who all should be referred? Any child with any insult to the growing brain, preterm, STOMI neonatal course, ROP, developmental delay, very poor attention, learning disability, everybody has to get a evaluation. Neuroimaging may be diagnostic value, but a normal MRI does not rule out CVI. Whatever you see in the MRI need not really correlate with the severity of CVI. Etiology of CVI may not correlate with severity or presentation, and CVI may manifest itself in unfamiliar environments. In home and in school, they may not have simultanagnosia. If you put them in a mall or in a new park, suddenly simultanagnosia will come, facial blindness will come. You cannot take for granted that a child, the same way they were in office, they were going to be there in the entire day-to-day life. So in new places, when there is stress, new problems, new functional disabilities will keep popping up. Plasticity in childhood is limited. Do not take for granted that it's a younger child, they will always improve. This is a compromised brain, and plasticity is always limited for you. And to summarize, functional vision is very important. Distance of communication should always be mentioned along with the contrast. Intervention, do not forget on multidisciplinary referral. If you don't know where to start, always work on the developing visual milestones. See up to what they have achieved, and from there start your rehab. And always remember that early intervention and cross referral are crucial to CVI. Thank you so much.
Thank you so much, Dr.